Kanski lecture series, and this is going to be the chapter 11, glaucoma part 5. And in this part we are going to study about the visual fields defects and the treatment of the primary angle closure or open angle glaucoma. Remember that we are already talking about the primary open angle glaucoma, but in this topic the writer has included all the kinds of investigations that you can do in a case of glaucoma. So that is basically the journal investigations. So that is why the topic is very long, but we just remember in the back of your mind that we are actually discussing the primary open angle glaucoma, and that is why after the investigations we will go to the treatment of the primary open angle glaucoma. So visual fields defect, it is one of the very important investigations that you must perform in a patient of glaucoma. So nerve damage in glaucoma is believed to be inflicted at the optic nerve head, and the resultant visual field defect correspond to the pattern of the fiber in the retinal area served. So the pattern, optic does have a different fibers that are being gone to the optic nerve. So the area which is affected depends, and then there is a corresponding visual field defect. Standard automated perimetry, SAP is relatively insensitive in early stages of the disease. Early changes. So, what will be the early changes in the patient of a glaucoma? So, early changes include the increased variability of the responses in the areas that subsequently develop defect and slightly asymmetry between the two eyes. Special modalities such as frequency doubling technology, FTT, and the short wavelength automated perimetry may demonstrate the defect in an earlier stage. So, basically, they in the early stages there will be the decreased sensitivity to the stimulus, and there will be the generalized decreased sensitivity, but especially in the area that is going to be the full blown defect in the future. So there will be the decreased sensitivity, and there will be the difference between the two eyes. So these early changes are usually being more readily detected by the swap. What is the swap technique? Swap is basically the short wavelength automated perimetry. It is a blue stimulus in a yellow background. I hope I'm reading it correct. So next is the paracentral, small paracentral depression. So as the small paracentral depression can form at a relatively early stage, often supranasally. They are more commonly seen in normal tension glaucoma. So you can see the figure 11.23a. So this is a paracentral scotoma. So what does it mean by paracentral scotoma? Is basically a defect. This is a central point, central fixation point, and you can see that it is there is a defect at the paracentral, and this is a left eye because the blind spot is in the left eye. This is a blind spot, whereas this is a central defect. Paracentral, not central, the paracentral, slightly away from the center, that is paracentral. So this is more commonly seen in a normal tension glaucoma. Next is a nasal step. Nasal step represent a difference in the sensitivity above and below the horizontal midline in the nasal field. The defect is bounded by the horizontal midline corresponding to the retinal nerve fiber layer, horizontal raphe, inferior optic disc, and OCT changes with the corresponding superior nasal step are shown in figure 11.23. So that is why there are more field that is in the nasal side than in the temporal side. Why? Because the nasal step are more common in a case of a glaucoma. So you can see that there is a defect that is nasal, is supranasally, and that is respecting the midline, horizontal midline. So you remember that in a case of a glaucoma, most likely it will respect the horizontal midline, whereas in a case of a neurological defects it will respect the vertical midline. So the defect will be like this in a case of neurological defect, and in a glaucoma it will be like this type. So this is a right eye because the blind spot is in the right side. Next is a temporal wedge. Temporal wedge is less common than a nasal step but has similar implication. So it is like corresponding to the nasal step is a temporal wedge. Then there is an arcuate defect. Arcuate defect develop as a result of a coalescence of a paracentral scotomas. They typically develop 10 degree and 20 degree of the fixation as downward or upward extension from the blind spot around fixation. With time, they tend to elongate circumferentially along the distribution of the arcuate fibers. So, the arcuate fibers are usually along the temporal side. So, basically, these are the paracentral scotomas that are usually joined together, and they are basically 10 to 20 degree away from the point of fixation, and they are like an arcuate fiber type. Then there is a then after that a ring scotoma develops. A ring scotoma is developed when a C and D is also showing. With time, they tend to elongate circumferentially along the distribution. So when they also enlarge, they will form whole of the arcuate defect, like a full blown arcuate defect, when the central fixation is also involved. So this is also showing us a full blown arcuate defect. Now this is a ring scotoma. A ring scotoma develop when the superior and inferior arcuate defect become continuous, usually in advanced glaucoma. End stage changes are characterized by the small island of the central vision, typically accompanied by the temporal island. The 10-2 perimetry pattern facilitated monitoring of the residual central field. So basically, this is a ring scotoma when the superior and inferior arcuate unite. There is just a small central island that will remain, and that is called the ring scotoma. That is present in a case of advanced glaucoma. So what is an advanced stage? It is basically a tunnel vision where very small central vision remain. So in a very basically you do the 30-2 pattern or 24-2 pattern in the case of glaucoma, so that you can have a more visual fields defect. But when there is very small, that you have a patient with a very small tunnel vision, and you want to do the, and that it is a very advanced glaucoma. So doing the 30-2, that there is going to be peripheral defect anyhow. So you do this 10-2 because you want to know about more about the vision in the center part. So that is why the 10-2 pattern is used in advanced cases, because only central vision is remain, and you want to just monitor that stage, that part of the visual field. Summary measures should always be considered. On average, the annual deterioration in a mean total deviation of just over 1 decibel can be expected in an untreated patient, but there is a significant individual variation. Natural history of open angle above. So we have discussed it in the early manifest glaucoma trial, that how untreated patients of glaucoma have a visual field defects in coming years. So next is a minimal criteria for glaucomatous damage on static automated perimetry. One of the following defect on the Humphrey visual field testing, HODAP, Parrish and Anderson criteria. Very important, very important, very important. Why? Because it is usually asked in the exams as well, and a very important viva question as well. So remember that these criteria are based on the two of the fields that you make the patient do, one on one occasion and another on the follow-up visit. So glaucoma hemifield test outside the normal limits on at least 2 consecutive occasions. This provide an information concerning differences between the superior or inferior half of the visual fields by evaluating threshold at the mirrored image point above and below the horizontal meridian. This program also compares the overall height of the hill of the vision with age adjusted normal values. So what is a glaucoma hemifield test? So basically it is one of the indices of the visual field. Basically, this is a pattern for example, you just take this visual field. So what the glaucoma hemifield test, it will just measure the sensitivity at some points in the superior side, and the same in the mirrored image point in the inferior side, and both of them are compared. If there is a significant difference between both of them, this is known as outside normal limits. So if these are outside normal limits in these two parts, then 2 consecutive occasions, then it means that and there is a glaucomatous patient. Next is a cluster of 3 or more non-edge point in a location typical for glaucoma, all of which are depressed on a PST, Patron standard deviation, of a P level less than 5% level, and one of which is P level less than 1% level on a 2 consecutive occasions. So this is a thing that he is talking about. Basically, this, let's consider this is a visual field, and that there is a paracentral defect in a case of a glaucoma. So you can see that yes, there is a defect and there is a paracentral defect, and you see that there are non-edge points, 3 cluster non-edge points, and you can see that 2 of them must all of them must be less than 5%, p value should be less than 5%, and at least one of them will have a p value less than 1%. So you can say that 2 of them should have a p value less than 5% and one of them should have a p value less than 1%. What does it mean that 5% or 1%? 5% and 1% mean basically that the defect is abnormal in 99% of the cases, and it can be normal in the 1% of the cases, whereas 5% mean that defect is abnormal in 95% of the cases, and it can be normal in 5%. So more the abnormality, the more it is significant. So in this case you can see that 2 of the points are at 0.5% and one of them is 1%, so it is meeting the criteria of the non-edge point, so it is a positive for glaucoma. And it is also done on the 2 consecutive occasion. Corrected pattern standard deviation occur in less than 5% of the normal individual on 2 consecutive field. So basically these are the 3 criteria that are met on the 2 consecutive occasion to label the patient a glaucoma at any case. So this is showing the 11.424 is showing the progression of the visual field defect and deterioration of the global indices over time. So you can see that there was a defect in this case. There is almost a nasal step in this case, and then it is increasing in size. It is becoming a kind of arcuate defect, and this is also increasing in size. We discussed this. And staging. So how will you stage the glaucoma on the basis of visual fields at mild, moderate, severe? It does depend on a discrete level staging system can be used to determine the stage of the damage. Early glaucomatous loss is mean deviation of less than -6 decibel. Moderate glaucoma loss -6 to -12, and severe glaucomatous loss less than -12 decibel. Any absolute defect 0 decibel in the central 5 degree is considered severe. So in the central degrees 5 degrees, if there is a 0 decibel, it is considered severe. Mild, basically mean defect is basically the indices in the globe field. What is a mean deviation? Mean deviation means that the sensitivity of each point, the average of the sensitivity of the each point. For example, you see that here it is written all the sensitivities of the patient, like in this mean deviation. All the sensitivities of the patient compared to the age matched normal. So what you do is basically take an average of every of all these deviations, and if this is less than -6 decibel, it is considered as a mild. It is between 6 to 12, it is considered moderate damage, and if it is more than -12, negative is bad. Negative is bad in a case of mean deviation. One should be in the positive range for the mean deviation. So if it is greater than -12, it is very severe or bad. And it is showing the mild glaucomatous damage. A is minimal cupping and B is showing paracentral scotoma. Here is a scotoma. Management. So this is showing the moderate glaucomatous damage. You can see that the mean deviation here is almost -5.3, and it is showing the arcuate scotoma. And severe glaucomatous, there is a marked cupping, and it is showing the severe visual field loss, and mean deviation is almost minus 14. Next is the management. How will you manage a case of a POG? We are discussing the primary open angle glaucoma, so we are discussing the management of that. The primary aim of treatment is to prevent the functional impairment of vision within a patient lifetime by slowing the rate of ganglion cell life. So you have to prevent the disease, and so that there is no ganglion cell loss. Currently, only proven method of achieving this is to reduce IOP. Both higher mean IOPs and substantial variation of IOP are predictive of progressive visual field loss in a patient with glaucoma, whether newly diagnosed or advanced. So, mostly you can do is to treat the IOP. An explanation should be offered concerning the nature of the disease and relevant literature provided. The timing of the medication should be specified, and the patient educated in the technique of the eye drop installation. Very important, because sometimes we are unable to communicate to the patient that how important this disease is and how important that you have to take the topical medications, because the patient uncarefully do not take the eye drop seriously, so they are non-compliant, and which can loss to the progressive visual field loss in the patient, especially in a case of advanced glaucoma. At follow-up visit, the patient proficiency of instilling drops should be checked in order to maximize drug contact time in the anterior segment and to minimize systemic absorption. The patient should be instructed either to perform a lacrimal sac occlusion by applying the fingertip pressure at the medial canthus, or to close the eyes for about 3 minutes of the installation. Common or severe potential adverse effects should be explained at the commencement of the treatment, and their occurrence inquired about at the review visits. So basically, you have to tell the patient how to instill the drop. So what are the treatment goals? So one of the very important thing is you have to set the target pressure. Target pressure is basically that pressure below which the glaucomatous damage is unlikely. So this is the target pressure below which the glaucomatous damage is unlikely. It is assumed that the pre-treatment level of IOP has damaged the optic nerve and will continue to do so. An IOP level is identified below which further damage is considered unlikely. The target pressure, this is identified considering the severity of the existing damage, particularly a greater vertical CDR ratio and a higher mean deviation on visual field. The level of IOP, CCT, the rapidity with which damage occur if known, and the age and the general health of the patient. Greater age is associated with higher likelihood of the rapid progression, but a shorter life expectancy may also influence management. Therapy should maintain the IOP at or below the target level. If not achievable by conservative measures, a decision is made on whether to proceed to the surgery or to continue monitoring with on above treatment. So basically, you have set the damage, like you can see that if what are the CDR ratio, what is the mean deviation on visual field, what is the level of IOP, CCT before starting the treatment. So, and you have to see how much the patient life expectancy is, and based on that you can set the IOP and at or below the target level. So you should set the therapy that should be at the IOP or below the target level. A reasonable initial goal. So what will be the target IOP will be? A reasonable initial goal is to reduce the IOP to less than 18 millimeter mercury. So it is, you can say it is less than normal, like 18 millimeter mercury. This is based on the result of the advanced glaucoma intervention study. So very important, it is based on a study which found that a significant visual field progression is unlikely to occur in a patient in the medium term if the IOP is kept below the 18 millimeter mercury at all times. So basically, if a patient comes to you with a pressure of 32 millimeter mercury and you know that patient has a POG, now what will be your target IOP will be almost 18 millimeter mercury. What, based on the advanced glaucoma trial, that the below this IOP the glaucoma progression is unlikely. So you give the patient medication to reduce the IOP at least to the 18 millimeter mercury. Response to progression. The early manifest glaucoma trial found that for every 1 millimeter decrease in IOP, there is a 10% reduction in the risk of progression. So if you reduce the IOP by 1 millimeter, there will be the 10% reduction. When measured from the presentation to the first follow-up visit, as damage progresses, the loss of each remaining ganglion cell has a greater potential impact on the visual function, and there is a less reserve capacity. If the damage progresses despite a target pressure having been reached consistently, the target IOP is set to a lower level. If further damage is sustained despite apparently good IOP control, surgery should be considered. So basically, he's trying to tell that that optic and neuroretinal nerve has all the fibers of the ganglion cell nerve fiber layer. So what happens is that basically as the glaucoma progresses, each of the fiber become more important, because if even the one fiber that, because in like if you are just there is a bowl of sugar, if you take a fist of sugar and put it somewhere else, then the bowl still remain full. There is not much of the difference that it makes. But when there is a very small amount of the sugar that remain, even the one granule become important. So similar is the case with the optic nerve, that if the glaucomatous damage is involved, so any remaining fibers become very very important. You do not want to lose even that one fiber. So you just set the target IOP and you achieve it. If still not achieved, the target, the glaucoma progression does not decrease with that, you just tend to decrease target IOP to more lower levels. If still not, then surgery is the therapy. So what is the medical therapy that you will consider? See later in this chapter, commencing medical therapy. So it is just giving us a basic principles of how to treat the patient with the poke. Any drug chosen should be prescribed in the lowest concentration consistent with the desired therapeutic effect, and administered as infrequently as possible. Ideally, the drug with the fewest potential side effects should be used. Initial treatment is usually with one type of medication, typically a prostaglandin analog or beta blocker. So basically, you have to give the patient a drug so that he use with the lowest concentration possible and to the lowest doses possible. Review. The interval to review after starting medication is set according to the individual patient, but is usually 4 to 8 weeks. So you cannot expect the patient to just give the drugs and therapy and come after 2 weeks and then check the target IOP. You have to at least give a patient 1 month to 2 months for to the drugs to become effective. Response to the drug is assessed against the target IOP. If the response is satisfactory, subsequent assessment is generally set for the 3 to 6 months. So glaucoma patient does not just you have to give up on the patient. It is a long-term follow-up. A patient should follow with his or her ophthalmologist for the lifetime period. So just to be on the safe side. So you just assess the patient after 4-8 weeks. If the assessment is satisfactory, you just ask the patient to come after 3 months or even 6 months. If there has been little or no response to the initial drug, is withdrawn, another has substituted. So if you see that after 2 months there is no response, you just withdraw the drug, another is substituted. If there has been apparently incomplete response, another drug might be added or a fixed combination substituted. But if there is some response, then you just add a drug, or you can just use a fixed combination. When 2 separate drugs are used, the patient should be instructed to wait 5 minutes before instilling the second drug to prevent the washout of the first. Sometimes it may be worthwhile to allow a further month or 2 for the treatment before altering a regime, as response may improve over time. Inadequate drop installation technique should be considered as a cause of unsatisfactory IOP response. So these are some of the patient instruction that you must give before the glaucoma, because inadequate drop installation, poor adherence should always be borne in mind. For example, if progression occurred despite excellent IOP reading at the review assessment. When drops are administered in the morning, it is good practice always to ask patient whether the day dose has been used prior to attendance. Perimetry. If IOP is controlled and glaucomatis mild or moderate with no substantial threat to central vision, perimetry after every 6 to 12 months is generally sufficient. Gonioscopy should be performed annually in most patients because the anterior chamber angle tends to narrow with age. So these are just the principles of the treatment, that how you treat the patient. You do perimetry after 6 months, you do gonioscopy 1 year. Optic disc examination should be performed at each visit, as an disc hemorrhage may indicate ongoing damage. A new hemorrhage should be recorded pictorially, optionally by photography. Serial imaging is increasingly reviewed as the standard care. Cause of treatment failure: inappropriate target pressure. If the IOP is maintained in the upper part of the statistically normal range, progressive video field loss is relatively common. Poor adherence to the therapeutic regime occur in at least 25% of the patient. A wide fluctuation in IOP are not uncommon in patients treated medically and are associated with the tendency to progression. Patient may deteriorate despite apparently good IOP control. Causes include occult adherence failure, undetected diurnal variation, and possibly other mechanisms not readily detected clinically, such as impaired optic nerve perfusion. The possibility of an alternative pathology, particularly a compressive lesion, should always be considered in these circumstances. Laser trabeculoplasty. Selective laser trabeculoplasty (SLT) is often as effective as medical monotherapy and has been gaining popularity as a first line of treatment. So this is basically a laser is applied to the trabecular meshwork. So and it causes the changes in the trabecular meshwork, uh, and these are sometimes used as a um, first line of treatment because it is as likely if you give the monotherapy to the patient. Surgery: the trabeculectomy is the surgical procedure most commonly performed for POC. In recent years, the threshold for glaucoma drainage devices implantation has been lowered by many surgeons. Non-penetrating surgery, for example, deep sclerotomy and viscocanalostomy, is utilized extensively in POC by some specialists. The role of microinvasive glaucoma surgery is being investigated, but there is no long-term result available. Phacoemulsification alone is frequently associated with 15% fall in IOP, but is generally offered to patients in whom significant opacity is present. It can be combined with a filtration procedure. Progressive damage is more likely to be slowed after surgery, probably because of the reluctant IOP is often significantly lower than a preoperative uh, level, is less likely to fluctuate because the adherence is no longer a factor. So basically, surgery is done in a case of advanced glaucoma and is commonly performed for POC. And these are all the surgically. Trabeculectomy is basically the mainstay of procedure, but there are new investigations, that are new procedures that have been utilized. Especially phacoemulsification has been, if a patient has having glaucoma and cataract, you tend to perform the phacoemulsification. It will reduce the 15% of the IOP. But also during the phaco, you apply the glaucoma devices. Minimally invasive microinvasive glaucoma surgery is performed. You insert the stent in the trabecular meshwork, and this also lowers IOP. Prognosis: most patients with POC will not go blind in their lifetime, but the incidence of blindness varies considerably depending on multiple factors such as presence of advanced damage at diagnosis and non-compliance with the treatment. In a wide population with POC, the lifetime chance of blindness in both eyes has historically been 5 to 10%. Given the long-term nature of progression in glaucoma, the prognosis appears to have significantly improved with new treatment strategies. The average period from the diagnosis to death has been estimated at around 16 years, and only about third will still be alive 20 years after diagnosis. So it depends on the patient life expectancy. That for example, most of the time that a glaucoma is damaged, is diagnosed at a stage where after that the life expectancy is usually about 16 years, and you don't feel that a patient will go blind because of the glaucoma. So this is prognosis was not so bad. So that is set for the glaucoma part 5. See you in the next lecture.